I am really delighted to be here today. I'm Marina Adshade. I'm a faculty member at the Vancouver School of Economics. I'm one of the co-leads for the Women's Health Cluster, and it's a real delight to be here today to welcome and introduce Dr. Tenkorang. Dr. Tenkorang is an Associate Professor of Sociology and is cross-appointed to the Division of Community Health and Humanities at Memorial University of Newfoundland. He's very unimpressed with the amount of snow that we talked about having today, which has disabled our city. Dr. Tenkorang received his PhD in sociology from the University of Western Ontario, which is now Western University in Canada, in 2008. Over the past few years, Dr. Tenkorang's research has broadly examined the social and cultural determinants of health among at-risk and vulnerable populations in developed and developing countries. Specifically, he's been interested in sexual reproductive health of youth and women in HIV epidemic parts of the world, mostly in sub-Saharan Africa. His research interests have expanded to examining the social cultural underpinnings of intimate partner violence in several African countries. Fun fact about Dr. Tenkorang, he likes to listen to his native Guyana folk music called High Life in his leisure time. I think I'm going to check that out.
Yeah, you should.
Is it relaxing? Because this is what we all need right
now. It can be a little bit hyper, but but you can find high life music that is also very relaxing. Yeah, sure.
Before we begin, I just want to start by saying that we recognize that we live, work, and play, and participate in community on the unceded and ceded and traditional territories of 203 First Nation, along with 38 Métis charted communities, each of which possesses their own unique traditions and history here in the land that we now refer to as British Columbia. We acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action, the United Nations Declaration on the Rights of Indigenous Peoples, and the BC Declaration on the Rights of Indigenous Peoples Act. In all of our work, we're committed to ensuring Indigenous women's rights to health and safety and the equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. Today, I'm joining you from Vancouver, which is part of the unceded homelands of the Coast Salish peoples and the traditional territories of the Musqueam and Squamish and Tsleil-Waututh First Nations. So we are here today as part of the Women's Health Cluster. If you're not familiar with the cluster, I encourage you to check out our website. We are an active and lively group of researchers from across the country and researchers around the world who are interested and engaged in women's health. We have a number of things that are going on at all times. We have a trainee research presentation series. We have our health series that we're here today for. We've had a tri-cluster research day, community events, and so on. I've organized two big events as part of my perspective as being more from the socioeconomic perspective. So we're an active group, and we also have a newsletter, so you should sign up for that and keep appraised of the work that we're doing. Okay, so without any more delay, I want to welcome Dr. Tenkorang, and very much looking forward to hearing your thoughts. We will have time at the end to ask questions. So you can put them in the chat, or you can wait and ask them at the end. So thank you very much for being here.
Thank you. So can you see my screen at the moment?
Yes, we can. Okay,
so I just want to first of all thank the Women's Health Research Cluster for this invitation. I'm really very excited to be here, I have to say. And I would like to extend similar gratitude to Dr. Adshade for the generous introduction. Just to add a little bit to that introduction, after receiving my PhD from Western University, I pursued postdoctoral education at the Social Justice and Sexual Health Research Lab, University of Windsor. I thought I should just add this mainly because throughout my doctoral and postdoctoral education, my research interest focused extensively on women's reproductive health outcomes in HIV endemic parts of the world, particularly sub-Saharan Africa. My research interest on gender-based violence and intimate partner violence coincided with my appointment at Memorial University of Newfoundland in 2011. So that means that for the past 10 years, I have been doing work on gender-based violence, intimate partner violence. But I need to also highlight that my current research on gender-based violence and intimate partner violence is not completely divorced from my previous research interest. In fact, my previous research interest on women's health, women's reproductive health informs, motivates, and inspires my, current research agenda. My current research agenda on gender-based violence. To bring a little bit of context to this, over the past 10 years, in the past 10 years, I was involved in a project that examined the housing and health outcomes of HIV positive persons in Ghana. Now, this project had nothing to do with gender-based violence and intimate partner violence, nothing to do with it. But as we collected data and began analyzing the data, especially the qualitative components of the data, we saw strong themes emerge around gender-based violence and intimate partner violence. Very, very strong themes emerge around this. Situations where women give sordid accounts of their experiences with physical and sexual abuse and what they thought were their own perceptions of how these types of violence affected their health outcomes, and also their chances of even reinfection with HIV and AIDS. Now, so at that point, I started to reflect, especially at the end of the project, I started to reflect and started asking myself questions. I wanted to actually go in that direction to see, to kind of begin to do work that links gender-based violence, intimate partner violence with health outcomes, HIV transmission. So as I started doing my research in the area, I realized that a lot hadn't been written on gender-based violence itself and intimate partner violence itself. In African contexts, and meaning hasn't been really given to these types of violence in African context. I then had to, probably do a detour and forget that my originally intended ideas of exploring these links between gender-based violence, IPV, and health, to kind of begin to see how best I can contribute to the literature on gender-based violence and IPV per se on itself. So in the last 10 years, my attention has been devoted to unearthing the socio-cultural underpinnings of gender-based violence, especially in African contexts, right? That's what I've done. Now I'm at the stage where I think it has become important to begin to extend some of these to the health outcomes of the women, to explore this link. So this paper I'm about to present actually is one of the few papers that I've started developing in that regard or in that respect. So you see that in this paper, I focus on economic abuse. I focus on economic abuse mainly because this type of abuse is marginalized. It is not often talked about. You often see in the literature scholars talking about physical, sexual, sometimes emotional, psychological abuse, and you rarely hear economic abuse in the discourse. Now, in North America and Europe, we have seen this kind of literature emerge, especially in the United States, because I know that there's been some work done in the United States on economic abuse. But when it comes to Africa, you rarely would see anything, written on economic abuse. Specifically in Ghana, I can boldly tell you that a lot of the work the few work that has been done actually comes from my own lab, my own camp. So I feel very happy to be able to do this kind of work because I know that it's similar to physical, sexual, psychological abuse. It also affects women's well-being. So in this presentation, I would first of all begin by giving the audience a brief reflection or discussion on intimate partner violence in African settings, and then would narrow down to talk about economic abuse and the various types of economic abuse, and then would draw theoretical and empirical links between economic abuse and health outcomes. Because this is a quantitative study, I plan also doing a brief discussion of the data And also we'll talk briefly about the statistical techniques deployed to model the data. We'll get to show you my findings, my results, and then discuss the findings. And then if you have any questions, I would like to take them. As we all know, intimate partner violence, domestic violence, gender-based violence are significant global problems, right? They are worldwide problems. They cut across various cultures, societies, socioeconomic backgrounds, racial backgrounds. In fact, the United Nations refer to gender-based violence and IPV as a global pandemic. And the reason why they would refer to it that way is mainly because of the statistics. The statistics actually bear it out. We are told that globally, 1 in 3 women have experienced physical and or sexual abuse. But although this problem is a global problem, I think the problem is more pronounced in sub-Saharan Africa. It's more pronounced in sub-Saharan. And I say this mainly because if you look at the data from sub-Saharan Africa, it's even damning and scarier than what you find at the global level. In Tanzania, a country in eastern part of Africa, we are told that about 61% of women have experienced physical and or sexual abuse. And quite recently, there was some research done by Mulune and colleagues. Just last year, they released it, and their study was more a systematic review and meta-analysis of the literature in Africa. And they reported a pooled IPV prevalence of 41% for the African continent, which is higher than the global prevalence, However, in Ghana, where I apply my trade, about 1/3 of women have been documented to have experienced all forms of IPV. Now, as someone who works in this area, when I see these statistics and data, I get worried, obviously. Now, the reason why I get worried is mainly because I know that intimate partner violence actually has consequences for women, right? It's, for instance, undermines women's ability, household and sexual autonomy. And this has been demonstrated in the literature. When I say household autonomy, what I mean is that women's ability to be able to make independent decisions for themselves and decisions for persons within their household. Intimate partner violence undermines that. And it undermines their sexual autonomy. And here by sexual autonomy, what I mean is women's ability to be able to control their sexuality and also make positive decisions that affect their sexual reproductive health outcomes. In the literature, we've seen some work that also demonstrates that intimate partner violence affects the health and psychosocial health outcomes of women. Now, because this presentation focuses on this theme, I wouldn't want to get into it a lot more. I think in subsequent slides, I'm going to be getting a lot more into that theme of how IPV affects health outcomes. That quite recently, we've seen the United Nations come up with some sustainable development goals. And these look like a framework with full of targets, right? Made up of targets that countries around the world are expected to meet, especially those in the developing world and particularly those in Africa. One of these targets is to be able to ensure gender equity, right? And to be able to bridge the gender inequalities that exist within and across nations. But it's an argument that this whole idea of gender equity can only be bridged, gender inequalities can only be bridged if we are also able to reduce and eliminate intimate partner violence. So here, my argument is that IPV, if not reduced or completely eliminated, would definitely be an obstacle, right, to achieving gender equity and to meeting the sustainable development goals as laid out by the United Nations. Now, at this moment, I think it becomes important to ask this question. I think the question is very legitimate. Why women in sub-Saharan Africa and Ghana are vulnerable to intimate partner violence. And when I ask this question, I don't mean that women elsewhere in the world are not vulnerable. All I'm saying is I think what I ask this question in acknowledgement of the fact that probably women in sub-Saharan Africa and Ghana would have vulnerabilities that are quite different and unique to women in other parts of the world. And also, I don't intend to kind of pretend I have an exhaustive list of why these women are vulnerable, right? Because it's impossible. The literature continues to evolve in this direction. So I wouldn't kind of argue that I have this exhaustive list. But if you look into the literature, you realize there are some factors or reasons that jump out at you. And one of such factors will be poverty and socioeconomic disadvantage. The literature makes us understand that women who are poor are often economically marginalized. And women who are economically marginalized also do often tend to be more dependent on their male partners. such dependence can easily lead to control and manipulation, which are at the heart of intimate partner violence, right? And there is also discriminatory gender norms. There's been lots of gender norms on the continent that perpetuate this kind of violence, and and gender norms that in fact target young girls and women. One of such norms will be child marriage. Child marriage is outlawed. I know in several countries around the world, it's outlawed. And in a lot of countries in Africa too, for instance, Ghana has criminalizes it. But in spite of the fact that child marriage is criminalized, the practice still is ongoing, right? In clandestine ways in these countries. For instance, in Ghana, we are told that about 20% of women marry as child brides, right? They marry before age 18, which is a lot. And my own studies have demonstrated that women who marry as child brides are significantly more likely to experience intimate partner violence compared to those who marry as adults in their life course. There is also what we call female genital mutilation, which is targeted at young girls, young women. It has to do with mutilating the female genitalia. While this has been criminalized in many parts of the world, including some countries in Africa, we continue to see this exist in many parts of Africa. Then there are a lot of, because of time, I wouldn't want to kind of get into this, but there are lots of gendered and lineage norms, if you ask me, that perpetuate these kinds of violence. We should also talk about women's lack of autonomy. A lot of women on the African continent actually lack autonomy, not able to make independent decisions, and sometimes have to depend on their male partners to do so. And as I mentioned earlier, that can lead to control and manipulation with intimate partner violence as a consequence. More recently, we've come to understand that pandemics, right? Pandemics through lockdowns and restrictions can increase women's vulnerabilities to IPV, or can interact in a complex manner with the existing social structures to affect women's vulnerabilities of experiencing intimate partner violence. And this has come mainly because of our coronavirus pandemic. I don't know if you guys heard, but during the pandemic, we saw that IPV rates skyrocketed, right? So there's been lots of gender-based violence researchers who have become interested in looking at these very complex relationship between how pandemics can also increase women's vulnerabilities. And I thought I had to throw in this just to let us know that outside of the traditional risk factors for intimate partner violence, like socioeconomic status and poverty, autonomy, and the cultural factors, we are beginning to also see how pandemics can create these kinds of problems. At this point, I want to be able to put on record that in as much as Ghana, IPV is a problem in Ghana, we do have a law that criminalizes intimate partner violence. The reason why I'll mention this is mainly because there are several countries in the world that doesn't criminalize domestic violence and intimate partner violence. In West Africa, I can mention a few. For instance, in Cote d'Ivoire, Ivory Coast, a country that is really very close to Ghana, right? We share borders with them. I think, to the best of my knowledge, this country hasn't criminalized domestic violence, including IPV. In Tanzania, in Mali, for instance, Mali is also a country in the western part of Africa. They've not criminalized intimate partner violence, domestic violence. In Tanzania, a country in eastern part of Africa, I don't think they have specific laws that criminalize their domestic violence. In South Sudan, we don't see anything like that. Now, Ghana's law, which we call the Domestic Violence Act, Act 732, was passed in 2007, about 14 years ago. And it criminalizes physical, sexual, emotional, psychological, and economic abuse. The reason why I want to really make reference to this is mainly because prior to the passage of the law, I think there was what I refer to as a culture of silence around issues related to gender-based violence. Not that people didn't want to engage with it. You had pockets of people sometimes talking about it, but people didn't really talk about gender-based violence, as if the Ghanaian society actually condoned that kind of violence. But then immediately after the passage of the law, right, in 2007, we've seen a liberalization, complete turnaround, where academics like myself have been empowered, civil society and policymakers have been empowered to engage with this problem. Also, I think it's important to make reference to the fact that the law empowered survivors and victims to be able to share their stories. disclose their experiences. So it is not very surprising, I'm sorry about it, it is not very, very surprising that immediately after the passage of the law, we've seen a barrage, right? A plethora of literature, especially when it comes to gender-based violence, intimate partner violence in Africa. We've seen that, especially in Ghana. We saw an exponential increase in the literature that discusses these things. The problem I have is that a lot of this literature so far has been truncated to these three main types of abuse: physical, sexual, emotional, psychological abuse. You rarely find people talking about economic abuse, not to even extend these types of abuse to the health outcomes of women. So it is this gap that I think we feel in the literature, right? It's this gap that I really wanted to fill in the literature. Now, at this point, I'm thinking it becomes important for me to begin to talk about the links between economic abuse and health. But before I do that, I would want to help us understand what economic abuse is, or to conceptualize this kind of abuse. Broadly speaking, economic abuse has been defined, right, as behaviors or attitudes that threaten individuals' economic security and their financial self-sufficiency. Now, but because this presentation is on Ghana, and Ghana criminalizes this kind of act, I thought it would be important for us to also know what the Ghanaian constitution, right, through the Domestic Violence Act, says about economic abuse. In fact, it defines economic abuse as the behaviors that deprives or threatens to deprive individuals of the economic resources due them by law. So this can include disposing of, hiding, hindering, or damaging of property. In the literature, sometimes you find that economic abuse is used interchangeably with financial abuse. But in this presentation and this work, we make conceptual distinctions between the two. Now, financial abuse would often refer to women's access to, limiting women's access to financial resources, right? So that is really very conceptually narrow. But economic abuse would often refer to limiting women's access to economic and social resources beyond their financial resources. So the distinction needs to be made between the two, right? One is broader, and we refer to the broader concept here instead of the narrow concept. There are three main types of economic abuse. The literature makes us understand, right? The three main types of economic abuse exist. We have what we call employment sabotage. Employment sabotage. And employment sabotage occurs when male abusers sabotage or attempt to sabotage their victims' ability to be able to gain or obtain employment, and also even maintain employment and any other means of economic survival. Now, this kind of abuse can manifest in several ways. One would be male abusers preventing their female victims from engaging in paid work, right? And it can also, manifest in male abusers disrupting and harassing female abusers from engaging in paid work, right? Sometimes they could also manifest in male abusers directing or misdirecting their female victims from employment opportunities that they prefer, that the female victims prefer, right? Or maybe even pushing them into precarious employment situations. In some qualitative work we've done, and I think in this presentation, I'm going to be drawing a lot on the qualitative work we've done, right? We found that a lot of the women had indicated that their male partners used employment sabotage as a tactic. They deployed this as a tactic to convey false protection. So a lot of the men would say, well, it's dangerous out there. The work you're going to be doing is dangerous, and I don't want you to get into it. It's better you stay home, because you are protected when you stay home, and it's better you don't work because there is danger. So they conveyed that as a tactic, to protect them, right? Staying home protects you. Engaging in paid work doesn't. And then we have economic exploitation. Economic exploitation occurs when male partners extort or they steal money from female partners with the intention of sabotaging, right, their economic well-being and prosperity. And this can manifest in male abusers borrowing money from female victims without paying the money back, taking money from their bank accounts without their knowledge, stealing money from their peers, and sometimes even damaging the properties of which they have material interest in. And that's what we call economic exploitation. And then we have economic deprivation. And the deprivation would occur where male abusers deprive and abandon women's household economic and financial needs. And this can manifest in ways like, not providing food in the house, failing to meet the, the financial needs of the household, and even paying paying probably school fees if there are children within the household. The male abuser fails to kind of do that. So such abandonment, these are very good examples of what we call economic deprivation. Now, we all know that intimate partner violence has demonstrated, there's a demonstrable link between theoretical and empirical links between intimate partner violence and health. And I say this mainly because in the literature, we've often seen studies that indicate that women who experience physical violence, for instance, are more likely to live with physical injuries, cuts, etc. And there's been studies that also show that women who experience sexual violence are significantly more likely to report sexually transmitted diseases, including HIV and AIDS. There's literature that shows that women who experience psychological, emotional abuse are significantly more likely to live with mental health problems, including PTSD, post-traumatic stress disorder, depression, anxiety. I've seen work that also connects physical abuse to women living with chronic diseases and even cardiovascular diseases. So the literature on IPV, intimate partner violence, and health is pretty much established. But the problem I have with the extant literature as of now is that it truncates this link between intimate partner violence and health to these three main types of violence: physical, sexual, psychological, emotional. I strongly believe that it has become relevant for us to elevate the discussions to also economic abuse. And so in this presentation, that's what I seek to do, to elevate the discussions to economic abuse. So if you think physical, sexual, emotional, psychological abuse have impact, then economic abuse can also have impact on women's health outcomes. So in this slide, I argue that economic abuse manifested in the three dimensions I've explained already can, in so many ways, can lead to economic marginalization, right? And this marginalization could mean poverty amongst women, could increase poverty levels among women. Meanwhile, we know that poverty is an important and a demonstrated determinant of poor health amongst women. Women who are poor have limited choices. They are less likely to be able to access healthcare, and as such would have poor health outcomes. There's also literature that, in fact, indicates that poverty increases the chances of food insecurity, especially within households. So women who are food insecure obviously are also more likely to be able to live with chronic diseases like hypertension, diabetes, stroke, and all those cardiovascular diseases. So we can see clearly theoretical links between economic abuse, poverty, and health outcomes. There's also been an anecdotal evidence that suggests that economic abuse can work in concert or in tandem with the other types of abuse to affect women. And I say anecdotal evidence because in the qualitative work we've done, we found that in a lot of cases, before women even experience physical abuse, right, they might have experienced economic abuse before that, right? So economic abuse in fact precedes sometimes physical and sexual abuse. And I say this mainly because we had lots of narratives where women will say, well, we were arguing about money and the distribution of financial resources within the household, and all of a sudden he hit me, right? So you could tell that, there were discussions around financial negligence, especially on the part of men, the male abusers, and then, conflict arises, and then you find, abuse, especially physical abuse. So we see how physical abuse, economic abuse can in so many ways work in concert or in tandem with all these types of abuse to affect the health outcomes of the women. Now, again, it must be also mentioned that in the qualitative interviews we did, there were instances where a lot of women had, for instance, complained about economic deprivation following their sexual unavailability to their male partners. So the male partners, in fact, had used economic abuse to economically control their partners, and that often leads to sexual control, right? So that means that the economic control transcends, the economic abuse transcends economic control to sexual control, and this we know undermines women's, autonomy, sexual autonomy, with implications for their sexual health outcomes. So we can clearly see theoretical pathways between economic abuse and health outcomes. Now, to be able to kind of tease out some of these relationships, we employed data, or we used data collected from Ghana. Nationally representative data collected between May to August 2017. The data were collected from over 2,000 ever married women aged 18 years and above. And for those of us who don't know really where Ghana is in the western part of Africa, and it has a population of about over 30 million, I have to say. It was a former British colony, right? But I think it gained independence in the 1950s, 1957 to be specific. So it's been almost over 60 years since it became politically independent. Ghana is often touted or often celebrated for it's often considered an oasis of peace, right? And it's touted for its democratic credentials, especially in West Africa. In West Africa, if you know the sub-region very well, you know that there's been lots of political instability within that region, right? So for Ghana to have been able to maintain its democratic rule for close to about 2 decades, we often pat ourselves on the back that we are doing great, especially when it comes to democratic and constitutional rule. So it's been a model of democracy for a lot of countries in the sub-region. And I want to be able to say, and I have to say that it's also a lower middle income country. To a very large extent, I believe that the political stability we've enjoyed have yielded, if you ask me, economic benefits, because I believe that it has helped in our economic transformation over the years. In spite of that, I want to be able to say that women live in the margins in Ghana. Women live in the margins. And the reason why I say women live in the margins is mainly because women in Ghana are less likely to get an education, more likely to be unemployed, and even if employed, more likely to be underemployed, and to earn a lower income. And, a lot of the women also work in the informal sector, right? So, poverty amongst women is really very high. And this is probably could be one of the reasons why violence against women is that high in the country. So for this specific project, so I hope that this gives us, for those of us who do not know where Ghana is, this gives us a little bit of context as to the country we are dealing with. Now, for this presentation, what we did was that we collected, the data we used came from a larger project, right? The larger project that was funded by SHEC, the Social Science and Humanities Research Council of Canada, from 2016 to 2020. But because of COVID, we've had an extension to 2023, I have to say. And the data, this larger study, in fact, sought to examine the help-seeking behaviors, not the health, but the help-seeking behaviors of female survivors of intimate partner violence. So here we were interested in the individual and institutional barriers that militate against women after they've experienced intimate partner violence and when they want to seek help. But, we had collected comprehensive data, right, on the experiences of the women regarding their experiences on intimate partner violence. And also, luckily enough, I'd collected some thorough data on health, the health of the women, cardiovascular health, sexual health, reproductive health, physical health, and psychosocial health. Now, in collecting the data, we used a very complex sampling strategy, multi-stage sampling strategy, where, first of all, we selected 2 districts from the 10 administrative regions in Ghana. Now, the administrative regions in Ghana is 16. We do have 16, but when we were collecting the data in 2017, it was 10 then, right? So we had about 20 districts, and out of the 20 districts, we used systematic random sampling to select 2 communities from the 20 districts, making 40 communities. Out of which we also selected households and individuals from the households to be interviewed. Now, because we focused on health, we thought it was important to provide also comprehensive measures on health, right? So we had 4 main health outcomes. One was cardiovascular health. And for cardiovascular health, we use 4 main indicators of cardiovascular health. Here, women were asked to self-report if they have been diagnosed of any of these conditions: non-gestational high blood pressure, high blood cholesterol, non-gestational diabetes, and stroke. So women who, for instance, had indicated at least yes on any one of these indicators, we had coded them as having experienced or having reported cardiovascular disease. Otherwise, no, right? Now, overall health, this was also a self-reported measure, and it was an ordinal variable where women were just asked to describe their overall health. So it was an ordinal variable. They had to just say their health was poor, good, and very good. And then we have psychosocial health. Psychosocial health was measured with 11 items, like it's measured on a 5-point Likert scale. And I have to say that because of time, I'm unable to go through all the details of the 11 items, but these were items that measure the psychosocial health outcomes of the women. And we use principal component analysis to create these measures. We extracted the factor scores. So this is a continuous variable, right, that measured the psychosocial health outcomes of the women. Then we have sexual health. Sexual health, which is more like a sexual autonomy variable. Women were asked whether they can ask their husbands or their partners to use condoms during sexual intercourse, and whether they can also refuse sexual intercourse from their husbands. For our focal independent variable, which is economic abuse, we tried to operationalize the 3 types of abuse that we had conceptualized earlier, right? So the first was employment sabotage. And for employment sabotage, we used 2 indicators. These indicators asked the women whether their male partners prevented them from engaging in paid work, and whether their male partners also forced them to quit their work, right? When a woman says yes to at least one of these, we say they've experienced employment sabotage, otherwise no. And then economic exploitation was operationalized using 3, right? Here, the women were asked whether their husbands withdrew or male partners withdrew cash or personal savings without their permission, control their belongings, material possessions, and damage their property, right? Women who said at least yes on at least one of them would have experienced economic exploitation. And then for deprivation, the women were asked whether they refused. Their partners refused to give them enough housekeeping money and deny them food, right? And other basic needs. And again, we use the same coding scheme for this variable. Now, because we had to use the socioeconomic and demographic characteristics of the women as control variables. And also, you remember earlier I had talked about this confounding relationship between economic abuse and the other types of abuse: physical abuse, sexual abuse, emotional, psychological abuse. Because of this, we had to control this in our modeling just to ensure that we have the independent effects of the economic abuse. For our data analytical strategies, we use various types of regression models, right? We had 4 main outcomes. The first outcome was cardiovascular disease, and that was a binary outcome. Because it was a binary outcome, we used binary logistic regression to analyze that. Our second outcome, which was physical health, was an ordinal outcome, overall health. So we use ordinal logistic regression to analyze that. And then the third was a scale, a continuous variable. So we use OLS, ordinary least squares, or linear regressions. The fourth, sexual health, also dichotomous variable. So we use binary, logistic regression. But if you look at the data as I described it, the data we use are very complex, right? They are very, very complex because they are hierarchical in nature. You have individuals nested within households nested within communities, and communities nested within districts. Such data structures can really pose analytical challenges because of clustering in the data, because individuals are clustered in the structures we've just talked about. Clustering can violate some of the assumptions underlying standard regression techniques, like the independence assumption. To be able to, and by violating it, they can also bias standard errors and can affect our statistical inferences. So to ensure that we had statistically robust parameter estimates, right, we had to control for this clustering by using random effects, which is almost like a random effects models, which is almost like a multi-level modeling, right, that allows you to be able to determine the nature and extent of clustering, the significance of clustering in the data. Now, as you can see, the results we do have, I show you descriptive results. 22% of the women said they had cardiovascular health problems. You had a lot more women saying the overall health was good or very good. And then on psychosocial health, we take the mean of that. And you can tell that women didn't think that they had severe psychosocial problems. It was low amongst the population, amongst the sample. On sexual autonomy or sexual health, a lot of the women had indicated that they had higher sexual autonomy. They can ask their husbands to use condoms during sexual intercourse and can also say no to sexual intercourse. On the economic abuse variables, we can tell that economic deprivation, a lot of women experience that. About over 40% of women said they had been deprived economically, followed by economic exploitation, 24%, and about 9% are indicating employment sabotage. Now, the next results I show you are bivariate results, and the bivariate results are just to show us the gross effects of our focal predictor on the outcomes we do have here. The outcomes, obviously, the health measures, and as you can see, economic abuse as measured with these dimensions are statistically associated or is statistically associated with the various health outcomes. Women, for instance, who indicated they had experienced employment sabotage were more likely to report that they have a cardiovascular disease compared to women who didn't, and they were more likely to also say that their health was poor compared than to say good or very good, and they reported positive values on psychosocial health, meaning that they are poorer psychosocial health. Now we find the same consistent results for economic exploitation, but just to add that the women who said they were economically exploited were less likely to be sexually autonomous, meaning that they were less likely to say they could use condoms during sexual intercourse. They could ask their husband to use condoms, and also say no to their husbands. And again, we see similar results for economic deprivation. I don't want to dwell on the bivariate results that much because I know that it just shows the gross effect. Now, the most important results become the multivariate results, because this is where we control for the socio-demographic and economic characteristics of the women. And also, this is where we also control for the confounding effects from the other IPV measures. Here, we see that a lot of the effects we saw at the bivariate level have been attenuated, but we continually also see that some measures or some dimensions of economic abuse are still statistically associated with the health outcomes of women. So for instance, we see that women who said they experienced employment sabotage had poorer psychosocial health outcomes, right? They had poor psychosocial health outcomes. Those who said they were exploited by their male partners were more likely to report cardiovascular health problems, and had poorer psychosocial health problems, and were less likely to be sexually autonomous. We also find that those who said they experienced deprivation were significantly more likely to have psychosocial cardiovascular diseases, more likely to report poor health, than to say they have very good or good health, and also more likely to say they have poor psychosocial health. So what does all these tell us, right? If you look at all these results, what does it tell us? Now, generally, we believe that our findings indicate high prevalence of economic abuse in the Ghanaian population, as per what we've seen in the sample. Like we saw, over 40% of the women had indicated that they had been deprived economically, followed by 24% of women who said they had been exploited, and 9% of the women who said they had experienced sabotage. Now, this finding we think is not very surprising, because in 2016 there was a larger study in Ghana, right? A larger study in Ghana. This study was conducted by the Ghana Statistical Service in collaboration with the Institute of Development Studies at the University of Sussex. And in the history of the country, this has been probably the largest study on domestic violence and intimate partner violence in Ghana. And the preliminary findings from this project was that economic violence was the commonest form of violence in Ghana. We think that our findings in some way corroborate this. We strongly think that. Again, we were not too surprised that economic deprivation and exploitation were the two most common types of economic abuse as seen in our sample. Not too surprised. The reason why I'm not too surprised is mainly because from the qualitative work we did, we had realized that a lot of the women had talked about these types of violence perpetrated against them after their sexual unavailability to their male partners, meaning that their male partners, in fact, use this as forms of punishment, right? Okay, I'm not going to be giving you the money. I'm not going to be taking care of household duties. I'm not going to be financially responsible anymore, mainly because you didn't, give me sex the night before, So a lot of the women talked about, these types of violence following their sexual unavailability. For employment, for economic sabotage, we also, especially coming from the qualitative data, saw several instances where female partners would tell us that their male partners accuse them of infidelity when they made attempts to engage in in paid employment, and this was really like a very, very big problem. Some made promises of monetary even rewards for these female partners, which was never met. Now, our findings would also have demonstrated that especially all the measures we had on economic abuse had an impact on the psychosocial health outcomes of the women. We think this corroborates other studies we've seen in the United States and in Australia. And the reason why economic abuse would affect the psychosocial health outcomes of women adversely is not really far-fetched. Women who experience economic abuse are significantly more likely to, also go through financial stresses, and these financial stresses could lead to anxiety, and that can affect the mental health resources of the victim. Again, we've seen studies that have talked about how economic abuse can undermine women's financial independence and their economic autonomy, bringing tension within the household and having implications on the psychosocial health outcomes of women. Deprivation and exploitation also particularly affected the cardiovascular health outcomes of women. Now, this was a little bit surprising and not too surprising. Surprising really because there isn't lots of studies that in fact link economic abuse to the cardiovascular health outcomes of women. But we can see how this happens. Like we theorized earlier, right? These kinds of abuse can generate, economic marginalization and poverty. And poverty is a known risk factor for food insecurity. And we know that there are links between food insecurity and chronic diseases, cardiovascular, like diabetes, hypertension, and again, women experiencing this vulnerability may be accompanied with stress and anxiety, and these are known risk factors for hypertension, for instance. As for women going through economic exploitation and it affecting their sexual autonomy, I think qualitative work made us understand that sometimes men use this as a ploy, right, to economically control their partners, and such control often transcends into sexual control, which has implications for the sexual health outcomes of these women. So what do we learn from here? I think because of time, we learn that economic abuse, obviously, it's important to pay attention to this. I don't think that for a very long time, I think we have really marginalized this kind of abuse. You see lots of surveys that don't even collect, data on economic abuse. But I believe that this, going forward, becomes really important to focus on this type of abuse, mainly because of the implications it has for women's health. Now, I also believe that it becomes very important for us to begin to think about using qualitative data to flesh out the mechanisms that link economic abuse with health outcomes. There are virtually no studies on this area. I think this is really important. You could tell that in my explanations, I was drawing a lot on the some qualitative work we've done, because it becomes important for us to kind of interview the women and hear their stories, especially when it comes to this abuse and how it affects their health outcomes. And I also believe that from a policy perspective, it's become relevant for us to begin to go beyond, especially in diagnosing poor health. Right? It's become important for us to go beyond physical, sexual, and emotional violence to screen for economic violence as an important risk factor for poor health amongst women in Ghana. There are some limitations, obviously. I use cross-sectional data here, and I cannot make causal connections between my outcome and my outcome variables and predictor variables. And I also use retrospective data here, which is subject to recall bias. Domestic violence and intimate partner violence is highly stigmatized and sensitive. And so my data are subject to underreporting. I need to also talk about the fact that the relationship between economic abuse and health can be endogenous. It can be endogenous. While economic abuse can affect health outcomes, we also believe that women who suffer poor health can be economically exploited. Now, this problem of endogeneity obviously can be solved using longitudinal data, which is where this is going, right? Panel data can help us clearly disentangle these causal connections. But we still believe that this research becomes very important as a first step, preliminary first step to, bringing that awareness to the literature, right, and to policymakers that this needs to be paid attention to, just as we are paying attention to physical, sexual, and psychological abuse. Thank you very much.
Wow, thank you so much. I was taking notes, and one of the notes I went in and revised my course outline. I teach a course on women in the economy, and I made a note next year to teach them my class year material, because I think this is really, really interesting and important research. As an economist, I'm actually quite surprised at how understudied this is. You would think that economists would be all over this type of material. So it's really, really fascinating. I have questions.
Sure.
I'm happy to take other questions, but maybe I have many questions actually. But when I guess the first thing that really sprung to mind is, I don't think you can answer this, but I think when I listen to what you talk about economic abuse, I hear a lot of women who are sex workers are subject to exactly this type of economic abuse from their spouses, in part because they are sex workers and it's such a heavily stigmatized profession. When you did your research, did you actually speak to, was one of the questions you asked the women what their occupations were? Like, I'm kind of curious to know what type of work these women were doing.
Yeah, you're right. I think we, in the occupational category, had we didn't have a detailed occupational category, occupational variable, right? When I say detailed occupational variable, what we mean is what specifically the women were doing. I think it was more like, are you working? Are you not working? Mainly because we kind of were thinking about using this as control variables in our modeling. I think this is a very important, maybe something to think about, right? In Ghana, obviously, sex work is also criminalized. So it will be even very difficult for women to come out to tell you, well, I'm in sex work, right? Yeah. But I think you're right. It becomes really very important, and you're right that a lot of sex workers have had in the news, for instance, suffer from this kind of abuse, where they are economically exploited. Sometimes not only by their partners, but even clients. Yeah. So I think it will be very important to probably do work on this specific population with do this kind of work on this specific population. It's a very special, unique population, I have to say. The challenge will be getting the sex workers to talk to, especially given that this is criminalized in Ghana. I had my own graduate student, wanting to do research on sex workers, violence, among sex workers in Ghana. He couldn't get past the ethics board here, mainly because of the fact that sex work is criminalized in Ghana, and the ethics board here thought, obviously there could be some legal implications to this. So just to let you know how challenging this kind of work can be, especially in a context where sex work is really criminalized. Yeah, but I agree. Yes, thank you.
Yeah, there is some really interesting work on sex work in Senegal, which I think would probably be a similar situation. I have another question, sorry, and
that's fine.
Somebody else should ask a question. Is everyone here in a monog? I know that polygamy is illegal in Ghana, but it hasn't been illegal for very long. So a lot of women are probably in some women anywhere are still in polygamous marriages. Is everybody in the sample in monogamous marriage?
Oh, yeah, no, you're right. No, great question, because there is a paper I've done on polygyny. In fact, polygyny and polygamy, obviously, in Africa, obviously can come in two main types. We have polygyny and polyandry. So polygyny is when you have a man marrying several wives and several women, and that is very common on the African continent. But you also have polyandry, where a woman, can marry lots of men, and that is practiced among some African ethnic groups. And some even see that as a sign of women's empowerment. Actually, if a woman can marry several men, but you are right. I've done a paper using the same data I collected, on polygyny and marital violence in Ghana, right? And we do have, I think, close about 10% of the women, 10 to probably 15% of the women who identify with polygynous marriages. And these women have a higher risk of experiencing intimate partner violence, all the measures of violence we saw. In that paper, I sought to help us understand the mechanisms that link polygyny to intimate partner violence, because in the literature, we know for sure that women in polygynous marriages tend to be more likely to, it has been established elsewhere in Africa and even in Ghana. But my main concern was what would be the theoretical links, right? What makes these women more susceptible or vulnerable than monogamous. So yes, you're right. Polygyny is practiced. It's not illegal. In Ghana, we have several types of marriages. You can do marriage by ordinance. So if you marry by ordinance, and it's respected by the constitution, you can't marry another wife, or else you'll be charged of bigamy. But if you marry by what we call traditional marriage or the customary marriage, you can marry as many wives as you want. And because we have a quite significant Muslim population, you do have, for instance, Muslims marrying a lot more women, maybe 2, 3, 4 women, and even people who identify as traditionalists, right? Before colonialism, a lot of Ghanaians practiced what we call a traditional African religion, where they had the ability the chance to be able to marry as many wives as they want. So polygyny is accepted. Yes.
There's a question. Stephanie has a question, and if it's okay, I'll read it. She says, Marina's comment makes me curious about intergenerational cycles of economic abuse, much like we see with other types of intimate partner violence. Do you include questions about this in your data site? And would you be interested, also be interested to hear your thoughts on where interventions are best implemented to prevent economic abuse?
No, can you, because you're reading very fast, I didn't get some. Sorry
well,
about
the first question is actually, is there any way of measuring whether or not there's intergenerational cycles of economic abuse?
Yeah.
Like, so if a woman is more likely to be in a situation of economic abuse, are her children, her sons and daughters more likely to
I get that. No, I don't think we thought about that. I mean, personally, I think the literature, we are beginning to kind of, this type of abuse is often, like I said, it's marginalized, right? It's not something that we really would hear in the literature. So I think we're going step by step. And there's a point there that there could be intergenerational, cycles of abuse, right? We accept that, but in our data, I don't think we actually measured that. This will be something that I'll be really very interested, because at the moment I'm planning a longitudinal study and I think that question can be really looked at from that perspective too, right? That longitudinal, long-term perspective. So I'm planning a study on that would begin to kind of take these things into consideration. As to interventions, obviously there are several things that we can do for women. When the Ghana Domestic Violence Act was passed, there was this fund that they said they were going to be creating, which we call the Domestic Violence Fund, which we thought was a fund that could be used to help women. But at the moment, I don't think that fund has been activated, and I'm not very, very surprised, because usually, the policymakers and politicians in African settings, they tend to be very retroactive instead of proactive. So in a lot of the papers I've written, especially regarding interventions, I've made it known that it becomes really very important for us to begin to think about this fund in ways that can help women. Ghana is beginning to be, I see lots of women's empowerment strategies in the country, right? Where we're beginning to think about, for instance, empowering the girl child. We are beginning to break down gender barriers that militate against women's inclusion into the labor market. I think these are really very, very important things to do. We're already doing these things, but it needs to probably occur at a faster rate than we are witnessing. Because I know lots of people have questions, I'm trying to be very skimpy and sketchy with my answers.
Right, and we're actually out of time now.
Oh man, yeah, that's all right.
Should we ask one more question? And
Yeah,
then,
sure.
Lisa, is that okay if we stay for one more question? Yes, okay, good. Messi, you have a question?
Yes, yeah, hi, nice to see you. Sorry, I'm in my car. Thank you so much for bringing this very, very important conversation, because I'm advocate for economic abuse in Canada.
Sure.
So I'm very happy to listen your research and whatever all the findings. But in terms of the generation trauma, right now we are conducting nationwide study in Canada. Probably if anyone is interested, I can share you that. And in terms of also the intervention, we are developing the first state of economic abuse report. I don't know if anyone is interested, I can share. So it will be launching next month. Sure. And also we're gonna release the first research, what we are conducting during the pandemic. So what we have seen is during the pandemic, economic exploitation and economic control is exacerbated almost triple times in Canada. Yes. So the study is conducted in Ottawa. So I can also share, because it's a very important conversation for us. That's why I joined them. So I put my email out there, and then please check out our website. We have also a lot of resources. We have a national task force, like, organization across Canada. Also, they joined that. And then we are very happy in Canada. First time this issue is included in the National Action Plan. Still, we are advocating to include on the Divorce Act, in Canada. And also we are developing a nationwide, financial score map, financial security score map for a women, so that they can know where they are at in terms of financially, because one of the intervention is like, financial literacy, having those kind of standards, and also working on the economic abuse scale right now, what we are going to do. And also we're going to launch also the first digital platform for a women to flag those behaviors. So we have a great resources. We are the only organization in Canada so far. So I just jump here and then to share your resource. And if any also students out there, we have a lot of data. We want to scale up, this program, across the nation. So that's why I just share, my thought. I know it's not a question, but just to supplement, and it's very, very close to my heart. That's why,
This is wonderful, and please count me in, because I
put my email.
I would like to know a lot about this. I mean, and I kind of agree with you. You had indicated that during the pandemic, economic abuse. I had done some work with HIV positive persons quite recently. And even in the descriptive data, I see that economic abuse was the most common. It increased like threefold compared to what you see under normal circumstances. So I kind of agree with this. I am very, very excited that at least in Canada, we are paying attention to this kind of abuse, because my mantra and my message has always been, well, why are we not paying attention to this? Because this is really hurting women. It's affecting their well-being. And so I'm happy that at least I can hear things like this. I'll hear things like this. And I hope that in Africa, where I come from, we'll begin to follow suit.
Yeah, so let's connect and just take my email, check our website, and then I'm very happy to share. Yeah, thank you.
Really appreciate it.
Okay. This is really what the Women's Health Research Cluster is all about, right? Making connections coast to coast and around the world. So we're really delighted. Thank you so much for your contributions. Very much appreciated. And Dr. Tenkorang, thank you so much for coming. We are going to stay in touch, because I am really fascinated with your research, and I'm looking forward to seeing what comes out of it, because I think that this needs to be amplified. For sure. And I hope to hear a lot more discussions about this. So thank you very much. So much for joining us. We really, really appreciate your time. Thank you.
Thank you. Really appreciate it. Thank you very much. See you guys.